Hello, welcome, good morning, good afternoon, and good evening to all our speakers, yes, and the wonderful audiences in different parts of the world. Welcome to yet another edition of very educational lectures for you. The speaker for the first session of today is our honored guest from the USA, Professor Douglas Brockmeyer. Professor Brockmeyer currently serves as the Division Chief of the Pediatric Neurosurgery Program at the University of Utah, Salt Lake, USA. He also serves as a principal investigator on a variety of research projects involving the biomechanical genetic aspects of craniosacral disorders. Professor Brockmeyer specializes in pediatric neurosurgery, spine procedures, skull-base surgery, brain tumors, neurotrauma, and Chiari and vascular malformation. He has been an editor for pediatric neurosurgery, neurosurgical focus in pediatric cervical spine, neurosurgery clinics of North America, pediatric spine disorders, and section editor of neurosurgery. He is a spinal diseases and anomalies section editor of the ISBN Guide to Pediatric Neurosurgery. Dr. Brockmeyer has authored 89 peer-reviewed journal articles, 20 book chapters, and 1 book on advanced pediatric craniocervical surgery. Dr. Brockmeyer has given numerous local and regional and national lectures, and he has also been a visiting professor at multiple institutions in the USA as well as the rest of the world. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars, and today he'll be talking about pediatric craniocervical disorders, evaluation, surgical decision making, and treatment. The speaker for the second session of today is our honored guest from Japan, Professor Shiro Horisawa. Professor Horisawa is a consultant neurosurgeon and Department of Neurosurgery, Tokyo Women's Medical University, Tokyo, Japan. His research interests are focused upon lesioning surgeries like radiofrequency, gamma knife, and focus ultrasound. He also specializes in deep brain stimulation, spinal cord stimulation, and intracerebral baclofen therapy. He is an important member of the Japanese Neurosurgical Society and also a member of the board of directors at the World Society of Stereotactic and Functional Neurosurgery. He is a noted author with several publications in various peer-reviewed journals. He has also received several awards and accolades for his outstanding contribution towards neurosurgery in his country. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars, and today we'll be talking about surgical management of hyperkinetic movement disorders. The chair for the first session of today is our honored guest from Japan, Professor Nobuhito Morita. Professor Morita is Associate Professor, Director, Division of Pediatric Neurosurgery, Kitasato University School of Medicine, Sagamihara, Japan. Professor Morita specializes in the field of pediatric neurosurgery, functional neurosurgery, brainstem and spine surgery, including CVJ and intraoperative neurophysiology. He is the executive board member of the Japanese Society of Pediatric Neurosurgery and Pediatric Neurology, Spinal Surgery, Spina Bifida, and Asia Australasian Society of Pediatric Neurosurgery. He is an integral part of ISPN. He is also on the editorial board of the Child's Nervous System. He is a noted author who has published several manuscripts in various peer-reviewed journals and book chapters. We are extremely thankful to Professor Morita for accepting an invitation to chair the session of Professor Brockmeyer. The chair for the second session of today is our honored guest from Nepal, Professor Basant Pant. Professor Pant is the chairman of the Annapurna Neurological Institute and Allied Sciences, Kathmandu, Nepal. He is also the chairman of the Annapurna Research Center and past president of the Nepal Association of Neurosurgeons. Research centers on epilepsy, functional, and vascular neurosurgery. He is an important member of the NASON, WFNS, and ACNS. He is the recipient of several awards and honors for his outstanding contribution to neurosurgery in Nepal. He is a noted author with more than 80 publications and invited faculty to more than 300 conferences and workshops all around the world. We are extremely thankful to him for accepting our invitation to chair the session of Professor Horisawa. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I'd like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues from China, and we're extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Nobuhito Morita.
So it's my great honor to chair Professor Brockmeyer's lecture. Hi, Doug. And first, I will introduce him briefly. He graduated from Harvard College, majored in psychobiology, and got a Bachelor of Arts degree in 1983, and then entered Case Western Reserve University and got an MD degree there. And since 1987, he stayed in University of Utah for internship, residence, fellow, and the current position of the Professor of Neurosurgery and the Chief of Division of Pediatric Neurosurgery there. And as everybody knows, he is specialized in pediatric spine and craniovertebral junction surgery. And he has a lot of experience in pediatric spinal instrumentation. And I learned a lot from him, his paper regarding those fields. His lecture today is entitled as Pediatric Craniovertebral Disorder, Evaluation, Surgical Decision Making, and Treatment. I'm very much excited to listen to his lecture. So, Doug, please start your lecture.
Thank you so much, Nobu, for the kind introduction. It's really Terrific to see you again. It's been a long time, so thank you. And I want to say it's a great honor and privilege to be part of the Asian Congress of Neurological Surgeons. Again, good evening, everybody. I guess it's morning time for me. It's about 5:30 Utah time in the morning, so it's wonderful to be with you. My lecture today will be about pediatric craniocervical disorders, surgical decision-making and treatment. And this is a topic that's near and dear to my heart. And I want to share with you some standard concepts and then some new ideas at the end of the talk. So greetings from my part of the world, from Utah. Maybe some of you have visited us with our beautiful national parks. We play in the winter and we play in the summer too. So hopefully you can come join us at some point. But I think we're all getting tired of the online learning. I know that was me before and after. And hopefully this will all come to an end and we can see each other face to face. So by way of introduction, we'll talk briefly about each of these topics: classification, various types of disorders, review embryology and biomechanics, and how patients present and come in the door, what investigations are reasonable to get, how you're going to treat the patients, avoiding complications, which is very, very important, and then long-term follow-up. And then I want to talk about a few cases and some new concepts. So this is my practice presently. I have a general neurosurgery, pediatric neurosurgery practice, but my spine practice is basically divided here. I see a lot of congenital disorders, both locally in our region in the United States, and then throughout the larger part of the United States. About a quarter of the cases come from trauma, and then there's a smattering of tumors that come in. They're certainly less frequent, but we definitely see them. Most people are familiar with the traditional classification of congenital vertebral anomalies with disorders of formation, including the ones listed below, and then there's disorders of segmentation, including block vertebrae, segmental bars, and then there's other disorders that don't fall into those categories. And I think most people are familiar with them, and they're useful concepts. And it's important to know that the majority of these congenital vertebral anomalies are very benign and clinically insignificant. And we do screen a lot of patients and help a lot of parents out with their questions. And reassure them that everything's going to be okay in the majority of the time. So this is an old slide that I've borrowed, and it looks at defects of segmentation and formation in a pictorial way. So block vertebrae depicted here really has little potential for deterioration. Things are balanced on the right and the left side. Unilateral bars can deteriorate up to approximately 5 degrees per year. And if you have a unilateral bar and a contralateral hemivertebrae, that can deteriorate much faster at 5 to 10 degrees per year. Again, this is more thoracolumbar concepts, but it does pertain to the craniocervical area, and that's why I'm covering it. Defects of formation, we definitely see in the cervical spine. A fully segmented hemivertebrae can deteriorate 1 to 2 degrees per year. And then there's other ones that are much more benign, like incarcerated or partially or unsegmented hemivertebrae, and they have very little growth potential, and typically they're extremely benign. So in the that's on the coronal plane. In the sagittal plane, less is known about the effect of congenital vertebral anomalies on progressive kyphus, either in the thoracolumbar spine or in the craniocervical area. And some work has been done, but this has been covered in the orthopedic literature. So what are the types of pathologies that we see? And to start with, there's various classification schemes. This is one that I tend to use: the osteochondrodysplasias, disorders of bone and cartilage, including achondroplasia, chondrodysplasia punctata, dystrophic dysplasia, spondylopiphyseal dysplasia, And these are disorders that are classified on the right-hand slide that are not that uncommon, that I see fairly frequently in my clinic. And then there's connective tissue disorders, including osteogenesis imperfecta with the collagen 1A1 and 1A2 mutations, Larsen syndrome, Hodge-Duchenne syndrome, and then the mucopolysaccharidoses, including Morquio, Hunter's, Hurler's. And I'm not saying that everybody should memorize these lists, but it's just important to be aware of them and know how to classify them, so when you encounter them, you're able to manage them effectively. These are disorders that don't fall into those categories. So Down syndrome, Klippel-Feil, and Klippel-Feil variants, complex Chiari malformations, including basilar invagination and assimilation of the axis. You can have congenital spondylolysis, other pro-atlas disorders, osteodontoidium, C1 Hemi rings, which is something that we've described it. I think that the naming has caught on fairly well. It's where the C1 rings are not competent, and they're sort of falling off to the side, and they're blown off laterally, and they cause instability. So the embryology is very complex in the craniocervical junction. I'm not going to go into it in great detail, but just remind everybody that in the embryo, it starts off with the somites, and then evolves into the segmented and resegmented sclerotomes. And the sclerotomal anatomy ultimately dictates the positional identity of the different structures in the craniocervical junction. For instance, the green part here, the hypochordal bow, ends up turning into the pro-atlas area, or the lower portion of the clivus and the odontoid. And this becomes very important to be familiar with these concepts, so you can help classify the patients accordingly. It's also important to understand that Hox genes control the positional identity of all these vertebral and prevertebral segments. And then, for example, a Hox D3 mutation leads to partial loss of the C1 expression domain, and the C1 sclerotome ends up behaving like an occipital sclerotome, and that's how assimilation of the atlas comes about. On the other hand, a Hox D3 mutation can lead to a gain of function, and it can behave like an occipital sclerotome, where you have premature disjunction of the clivus, and the occiput can imitate the C1 segment, and that's how you get a separation here between the clival element and C1. So you need to be on the lookout for these. I think these are important. There's going to be much more coming in the next few years about these disorders, as we learn more and more about the embryology and the genetic, or the genotype phenotype correlations with Chiari syndrome, for example. So this is a very important slide, and I'm summarizing approximately 6 years of work in one slide. And we worked with the orthopedic surgeons in our biomechanics department at the University of Utah to create computer models of the craniocervical junction, look at finite element modeling. And the traditional determinants of OC1 stability, people would say it was the capsular ligaments, but the tectorial membrane was important in the stability of the OC1 joint, and the alar ligaments and apical ligaments. And it turns out, after an extensive review of the literature and our finite element model work, it turns out that it's the capsular ligaments at the, the capsular ligaments at the OC1 joints are the major determining stabilizing structures at OC1. So we look at the capsular ligaments primarily. Everything else is supporting structures there. At C1, C2, the major supporting structures include the transverse ligament. Most people know that, but the transverse ligament is more of a cruciate type ligament. That's the way the anatomy is there. And then the atlantoaxial capsular ligaments need to be taken into account. We're gonna talk about that in a little bit. That's very, very important to think about those capsular ligaments. And then obviously the integrity of the odontoid is important at C1, C2. And then the alar and apical ligaments are more minor stabilizing structures, but they don't provide major stability at that level. So these are very, very important concepts. So what makes these levels unstable at OC1? Obviously, you can have ligamentous damage from trauma, infection, tumors. Abnormal joint anatomy is very, very important, or malalignment of supporting bone structures from our topic today, the congenital vertebral anomalies. At C1, C2, you can have an incompetent odontoid, like an osteodontoidium that people have seen. You can certainly have dysmorphic bone anatomy, and I'll show examples of that, or an incompetent transverse ligament, again, either congenitally or from trauma. So normal load transfer, you have to remember that the weight of the head is borne through the occipital condyles, through the lateral masses of C1 into the lateral masses of C2, and those supporting structures need to line up. And that's I look at the coronal CT scans quite often, and here's a bunch of examples of coronal CTs at different ages, and you can see how things line up. Things don't shift and change over time. And this is a very, very important concept as well. So how do kids present? How do they come into the office, and what do they look like? Sometimes the presentation is incidental. We occasionally see kids from the newborn intensive care unit from just a chest X-ray. We see kids with chondrodysplasia punctata or other severe bone disorders in that way. Part of a trauma evaluation, that's not uncommon. Workup for a specific syndrome can happen if a patient has a neurological deficit. Obviously pain, torticollis, gait abnormalities, and so forth. So there's a variety of ways that people can come in the door. So next is how we investigate these problems. And I think if you polled most people in the audience, everybody would have a slightly different way of measuring the amount of motion on a flexion and extension X-ray. So what we did a study with a group of surgeons, and we tried to establish a validated way to look at this. So here's a patient with osteodontoidium, and you can see movement between C1 and C2, pardon me. So, so you can see that what the first step is to draw a reference line in front of C2 and carry that line up into the occipital area, and then you're going to measure two different structures. And one is front of the occipital condyle, and the second one is the posterior portion of the C1 arch. And you're going to measure the distance from that reference line in both an extension and flexion position. And you can measure those distances, either add or subtract to get the relative distance. And then the distance between occiput C2, you subtract the distance between C1 and C2, and that gives you the distance between occiput C1. So this protocol or paradigm was published in Journal of Neurosurgery. Here's the reference from 2020 that we did in Down syndrome. And this was a big problem trying to figure out the natural history of Down syndrome. But again, so you look at the C2 reference line, measure the distance between the front of the condyle and the back part of the C1 arch, and you can do the measurements. And this is very, very helpful, and many people have gone toward using this tool. So the second tool is CT scan, and you want to look very carefully at both the two-dimensional coronal and sagittal slices. You want to identify each vertebral level. Sometimes it can be very confusing, and it's a sort of a relative term. I call it a bag of bones. Sometimes it's extremely complex in certain patients. So you want to identify each vertebral levels, including the condyle, the C1 mass, lateral mass, C2 lateral mass, identify the joints, and that can help you identify the segmentation and formation anomalies that we talked about: clival disjunction, axis assimilation, C1 hemi rings, and so forth. And these tools are extremely important. So in this case, for example, here's an osteodontoidium. Here's the os fragment, and posteriorly is the arch of C1 here anteriorly. So you need to be able to identify these things in a positive way. And so we saw this picture before, but the CT scan really helps unravel the embryologic volatility of the craniocervical junction. And I would highly recommend this summary article from Dockling Pang and Dominic Thompson, published way back in 2010, but it's still relevant. Another tool or another reason to get the CT scan is you can look at the amount of rotational deformity at C1 and C2. And what I like to do is draw a line along the front part of C1 and then along the body of C2. You can measure the relative angles. In this case, it's 34 degrees. And when the rotation reaches 34 degrees, 35 degrees, that capsular ligament on that side of C1, C2 is typically blown and it's unstable, and it's very hard to hold that together. So, pardon me, my slides are skipping together before I'm ready, but I'll work with it. So at about 30 to 35 degrees with rotation, you really want to be aware of causing instability, and that's typically a threshold for fusion for me. And chronic painful torticollis from that deformity definitely needs to be fused. So MRI is the last tool, and you really want to focus on the joint, especially in trauma situations. We're not talking about trauma, but you want to talk about the occiput C1 and C1-2 joints. An abnormal signal intensity in the joint signifies injury and blood or instability. And then other ligamentous injuries to the tectorial membrane or posterior structures support the argument for instability at occiput C1, but don't make it. So here's a trauma example in CT scans taken from a patient, and we look at what's called the CCI, the condylar C1 interval, measure the distance. Over 4 typically will be representative of instability. So we have 4.1 across the board here. On the other side is 3.8, 3.0, 2.4. So it's separated in this child who had a trauma. Here's the MRI scan at the same exact slices that the CT scan shows, and you can see abnormal signal intensity within the joint here, especially on this side and on this side. Most importantly, on the midline image, you don't see any evidence of tectorial membrane injury. This is the STIR image, but you don't see any tectorial membrane image or any posterior ligamentous image. And then I took this patient to the operating room for fusion, and this patient is in pins, and we'll get this video to play, and I'm pushing gently on the back of the neck. So that's this patient. You can see how much motion is going on between occiput C1. This patient was grossly unstable with just that amount of distance between occiput and C1. So very, very important to understand that. And that's what led to the investigation of the finite element modeling and looking at these cases in more detail. So how do you treat these patients? There's certainly non-operative therapy that should be pursued. Conservative measures should be pursued in patients who have a benign natural history for their disorder, if there's no evidence of any pain or neurological deficit, and you don't think that the growth from their cranial vertebral disorder is going to affect their growth ultimately, that they're going to grow, they're not going to tip into kyphus or lordosis, or some type of coronal deformity will not occur. So you want to place patients into collars that are very young, that you know that are unstable, and you're going to wait a period of time. You might wait months, you might wait years. I've waited till kids are 4 to 5 years of age before pursuing fusion. So you're going to put that population in a collar. And so most of the time, sometimes it's a temporizing measure. Again, a patient comes in, they're 8 or 10 months of age, you know they're unstable, you're going to put them in the collar, and you're going to wait, and you're going to get x-rays over time. Planning for surgery is very important. You spend a lot of time on this part of it. You're going to look at the images very carefully. What levels are unstable? How many levels are you going to fuse? Is it even safe to instrument the levels that you're considering? You're going to keep it very simple, or you're going to turn it into a very complex procedure. You need to make decisions on instrumentation, bone graft, fusion adjuncts. Is the deformity reducible, which is extremely important. Are you going to use preoperative traction? And we're going to talk about that at the end of the talk here. Or are you going to do it all in one shot and just do an intraoperative reduction? And there's pros and cons to each of those arguments. So fusion techniques and instrumentation have come a long way in the last several decades, but everybody's familiar with the tools that we use in the modern techniques. And most people are using top-loading polyaxial screws with rods and plates. And these techniques are very adaptable. I just use the adult sets with outer diameter of the screws about 3.5 millimeters in outer diameter here. And those are obviously of various lengths. Occasionally I use a 4.0 outer diameter. And then the drill that you're using to create your pilot hole is typically about 2.7 millimeters. So take those into account, and you can measure your distances at C2 or C1 or whatever level you're putting the bones in, and look at that ahead of time. So this is our OR setup. This is an older slide, but typically the patient's in prone in Mayfield pins, and we have the fluoroscopy in place. Use the fluoroscopy to help place the instrumentation. This is a example of a patient from atlantoaxial dislocation. But a big important point is the foundation of the surgery is C2. And the axis, you need to be intimately familiar with the anatomy of the axis and the corridors that you can put the screws in. And you can see that's summarized in the lower slide here in different colors. And you want to be familiar with that, with the pars anatomy and the corridor where the screw would go down here. And then here's your entry point for the pars screw. I typically dissect out the pars before I place the screw, so I know the medial border, the lateral border, I can see it, and I know exactly where that screw is going to go. And then you can look at the anatomy directly from if you're thinking about putting a translaminar screw in, and you can see that directly. And then pedicle screws, I put those in much less frequently, but people do them. I routinely don't use stereotactic guidance to place the screws for a variety of reasons. I think if you're going to place a C2 pedicle screw, if you're not familiar with it, then image guidance would be a good idea. So the choices of the instrumentation can be sort of confusing at times, who you're going to put into what. Here's a graphical example of a combination case where on the right side, there's a C2 pars screw. On the left side, there's a translaminar screw. And then typically I'll place a rod plate construct. And then you can put rib grafts that span between the posterior arch of C2 and the occiput. And that's held in place with cable. And then I typically put a screw through the top portion of the rib into the occiput to put pressure on it and help stabilize it. These concepts were summarized in a paper we wrote a long time ago. And typically our plan A is to place a pars screw. It's very adaptable, and there's a lot of power for reducing deformities. So C2 pars screw is number one. And then the second alternative is a translaminar screw. Some people, as a third way, would put a pedicle screw. We typically would go down lower through the cervical spine and use the concept of load sharing to get more screws and share the load down the spine and perform the instrumentation that way. So avoiding complications is very important, and we wrote it. This is an older paper, but this is of 127 fusions. We looked at a variety of reasons for fusion failure, and the top reason for hardware failure by far was skeletal dysplasia or congenital spinal anomaly. And so I'm going to share with you some ideas in order to reduce failure rates. And so the factors that predicted risk for failure were obviously infection, where the hardware would have to come out, or at least the fusion would have to come out, congenital anomalies, and skeletal dysplasias. And there's some concepts that we learned. So the O-arm is very important, at least in my hands, to prevent malpositioned hardware. So what we do at the end of every case is that we cover the patient and we do a non-sterile spin with the O-arm, and we look at the screws and we know exactly where they're at. If there's any problem with the screw placement, and we go right back and we fix it at that juncture, and we don't wait. And this is very, very important. We use custom orthoses. Pardon me, this is jumping around. We use custom orthoses, and we keep those on. I think that's critical for success to reduce motion. And we really want to document fusion, and I get an X-ray. We'll talk about this at the end too. We get an X-ray at 1 month, at 2 months to make sure the hardware is intact. At 4 months, then you get a CT scan to make sure that the fusion is successful between occiput C2 or C1, C2, or lower down if you're going down into the thoracic spine or cervical spine. So here's our imaging protocol. So preoperative images, again, plain film, CT, MRI, intraoperative using fluoroscopy and O-arm. At 1 month, get an X-ray, make sure everything's holding together. 2 months, do the same thing. I typically skip 3 months. And at 4 months, I get that CT scan. Everybody's a little bit different with this, and we're in the middle of a project to try to do a survey to see how people do this around North America and even around the world, to see how different individuals assess fusions differently. I think that's going to be an important project. So long-term growth is probably one of the biggest questions I get asked. This is a paper from 2016 looking at 40 children under 6 years of age from a variety of centers, 3-year minimum follow-up. 9 atlantoaxial fusions had a mean of 30% cervical spine growth within the fusion mass. So the bone keeps growing around the hardware. 16 occipital cervical fusions had meaningful growth. 9 of them had no growth, and 6 of them had settling or loss of height. There were no abnormalities with alignment, either in the sagittal or coronal plane. So what I tell parents is that there's continued growth within the fusion construct in the majority of patients. And we haven't seen any significant abnormalities in cervical spine fusion in long-term follow-up. And I've seen kids back 16, 18 years in my career, and maybe some of you have as well, without any difficulty. So we're going to shift gears here. We're going to talk about C1, C2 quickly. There's 2 most popular techniques. Most people around the world use the Goel-Harms technique with C1 lateral mass screws and a C2 par screw coupled with a rod. It's an excellent way of fixation. I don't use it routinely. Sorry about the jumping around here. It's an excellent way of fixation. I typically will still put in C1 2 transarticular screws. I put in a lot of these over time. It's my preferred method. It's simple and it's elegant. It's relatively demanding technically, but once you get comfortable with it, it's very, very straightforward. It's okay even to put a unilateral screw, and you can easily reduce deformities using that technique. So speaking of unilateral constructs, I want to go back a slide. So, okay, well, the slides got shifted around, but that's okay. We're gonna move forward here. So here's the lateral fluoroscopy view for the transarticular screw, and here are your landmarks. Here's the vertebral artery ventrally, and then typically I put a dissector on the dorsal part of C2, and then the target point is the C1 anterior arch. And then here's the C12 joint. And that's, you want the screw to span that joint. And I typically treat it like a stereotactic procedure with an entry point and a target point. And that's very, very useful and in a safe way to place that type of screw. So the arthrodesis for C1, C2, very important considerations whether you're going to use an allograft or an autograft. I typically use allograft, structural allograft, iliac crest. I typically use BMP, and I put BMP at the contact points, both above and below. I'll wrap it with a multi-stranded titanium cable. I'll use that Sontag type fusion or Sontag type cable configuration, and it's very, very helpful. Contour the bone graft, and you want that graft to be under compression and under some stress. So the Wolff's Law takes over and the fusion can take place. So for C1, C2, we did a study with 131 patients in 7 centers. It turns out we were looking at predictive factors for C1, C2 fusion failure. Down syndrome was the one factor that predicted failure. And even if you take all those precautions that I just mentioned, it still has the highest failure rate. So there's something about the bone biology of those patients that we don't understand, and they're significantly higher risk, and you definitely want to have that conversation with parents. So in the last part of the talk, I want to talk about some new concepts and some cases, and that includes halo gravity traction, the possibility of vertebral artery embolization, and then the new concept of a classification scheme for these disorders. So we started doing this a few years ago. This is an old concept, at least in the orthopedic world, for thoracolumbar injuries, but for craniocervical injuries, the halo gravity traction is very, very helpful. So here's a boy with osteogenesis imperfecta, basilar invagination. We placed him into halo gravity traction for a week. This is his preoperative film. And here's his postoperative film and how much we were able to reduce his deformity. It was a very, very challenging case. We picked probably the hardest case we possibly could have as our very first case. And this was our result. So we're very, very happy with this. And he's done well in the long haul. Again, this is not a new concept, and a nice series was published out of Boston Children's Hospital in 2020. So here's another fairly extreme case, a 16-year-old boy with Emery-Dreifuss muscular dystrophy. He was fixed in this deformity, and we placed him into halo gravity traction, left him in traction for 2 weeks over a period of time. And then we took him to the operating room, put him in this position, and we had to do multiple cuts through the fascia to release the fascia as well. And then ultimately we were able to get him into a very, very nice neutral position. We had to go occipital cervicothoracic from occiput, and we put in thoracic pedicle screws to hold this. But the trade-off was far preferable to where he was at the beginning. So this is the power of this technique. Here's a young girl with neurofibromatosis who had post-laminectomy kyphosis. She had big napkin ring neurofibromas around her cord, which I took out. She fell over into kyphus in a rather extreme way, put her into halo gravity traction. We couldn't get her all the way back to neutral. She had a big plexiform neurofibroma in the front of her neck, which prevented us going from the front and prevented us, I think, from getting a full reduction. But we were very, very happy with this result, and she's done well. And it's occipital cervicothoracic. So here's a concept just to throw out there. It's not for everybody, but this is a 9-month-old girl with torticollis, came with us with this extreme torticollis abnormality from this tethering deformity at C2, C3, C4, C5 here. And I watched her for a couple of years saying, oh my gosh, what are we going to do with this girl? And the only thing I could come up with to get to this would be to release the tether above and below the bone, but the vertebral artery was in the way. So I had one of my endovascular colleagues perform an embolization of the vertebral artery on the side. You can sort of see the embolic material here. And then we did a one-stage reduction and got her back into you can see the embolic material, the coils and the material here in the vertebral artery, but did a fusion from occiput to the thorax when she was about 2.5 years of age. And we got her back into a really nice neutral position, and the parents were thrilled, rather than have to live the rest of her life with this terrible coronal deformity. There was another patient with a bad radiculomyelopathy, again with spinal cord compression, the vertebral artery. We just couldn't drill this out safely with the vertebral artery in the way. So we embolized that vertebral artery after the angiogram was performed. Get this to advance here. Again, sorry about the slides, but then we here's her coronal image showing the resection of the bone anomaly, and then the artifact from the embolic material. So again, extreme case, OI type 3, child 2012, 2016, severe basilar invagination. Kept going. We had hardware complications. I'm not going to go into detail. Just all sorts of trouble with him. Ended up putting him in a halo. We got him to fuse ultimately over time. Had him fused, but then he had this, we put him into a brace, thought that was the end of it, but developed this severe basilar invagination. And we did a CTA, couldn't resect this from the front, because his carotids came up and kissed together, and the ventral approach was out of the question. So again, we went back and embolized the vertebral artery and went in from a far lateral position and resected the odontoid. And I think we got a nice decompression on his cord. He's actually doing very well over time. And we followed him for a couple of years afterwards, and he's doing really, really well. So again, those are just concepts to think about when your back is really against the wall. So combined endovascular and pediatric approaches to complex disorders. We have 3 cases. We've done balloon test occlusions and a wake-up test, and all these lesions have been successfully resected. So the last is just very quickly about a classification scheme we're working on with orthopedic surgeons and neurosurgeons in North America, looking at using age. The region is a classification scheme, whether there's normal or abnormal motion, whether there's deformity, and using a neurocompression modifier. There's a lot of classification schemes like the Linky classification that use this routinely, and we're experimenting with it to see if we find it useful and see if we can come to an agreement about how this should be done. So more to come on this. These are the definitions of the motion index, including subluxation and angulation, and then the deformity index and the neurocompression modifier. And again, there's good examples of this in the orthopedic literature with early onset scoliosis, and that's been validated in different centers around the country and around the world. So in conclusion, there's a wide variety of these conditions. Most of them are benign. The surgical management is challenging but rewarding, and the surgical adjuncts like O-arms and so forth can lead to fewer complications. We still need to know quite a bit about the natural history of these disorders and the basic biological processes that are underlying this. And then we really need to establish a common language between neurosurgeons, orthopedic surgeons, and surgeons around the world, so we're all talking the same language. And I think our understanding would go further and faster. So thank you very much for your attention, and I am happy to answer any questions.
Okay, Doug, thank you very much for your excellent lecture. And is there any question from the audience?
We can, of course, invite Professor Muthukumar.
Yeah, Dr. Brockmeyer, that's a wonderful presentation as usual. I really enjoyed it. And this last concept which you presented, namely the preoperative endovascular procedure prior to difficult cranial junction anomaly. That is a new concept which I was not aware of. I think this I really learned something from you today. That's a new concept. I think that's something which we can do for certain specific complex cases where it is really indicated. So that's an alternative to vertebral artery mobilization. Am I right? So where the vertebral artery cannot be mobilized.
Yeah, no, thank you for that comment. Yeah, there are cases that it's indicated, and it's very, very few. But I think sometimes there are no other alternatives, and the point is that I think that's a safe way to approach that, and you need to have a very good endovascular partner because the anatomy can be challenging. But we're hoping to write that up and share that with other people. So thank you for your comment.
The next question is regarding the growth. You one of your slides, you had analyzed your cases. I think from the impression I got was the growth after atlantoaxial fusion was nearly normal, whereas in patients with occipitocervical fusion, nearly 50% had limited growth and another 45% or so had no growth. Why do you think it is so? Why there's a difference between occipitocervical and atlantoaxial, where the growth is affected in occipitocervical? Is it because of the construct is long?
I think the bone continues to grow and remodel around the hardware. I think it's just the growth plate. The first growth plate that's really present is the bottom portion of the C2 body, and then there's C2, C3, C4 down. So the longitudinal growth is happening from C2 down, and I think there's just a very small amount of growth potential at occiput C1 in the upper portion of C2. So I think that's the reason. And you're not fusing, and you don't get deformity because you're not fusing against an unopposed growth plate. So you don't get crankshaft, and I think that's I think that's a concept that, at least that's the explanation that I've arrived at. It's hard to prove, but I think that's the explanation I've arrived at.
Did you analyze the cases where you stopped the fusion at C2 and those cases where the fusion extended beyond to the subaxial cervical spine? Maybe those cases where the fusion extended to the subaxial cervical spine, they had greater limitation of growth, or the other group where the fusion was limited to OC and C2, the growth was probably better.
Yeah, you have to remember, the population, if you fuse occipitocervicothoracic, that population typically has limited growth potential, skeletal dysplasias and deformities. So there's limited growth potential to begin with. So, their vertical growth is minimal. And I just have not seen patients tipping into kyphus or crankshaft. And, we've been doing this for a long time, well over a decade, 15, 20 years. And there was one patient early on that we had trouble with, but other than that, we haven't run into trouble. So, you'd think that, the anterior column continues to grow, you get deformity, but we just aren't seeing it. So
that's exactly what I'm trying to make. In my experience, also, I have found it's more of this crankshaft is probably more of a theoretical concept. In day-to-day practice, we don't come across in the craniovertebral junction.
Correct.
Thank you so much. The lecture was wonderful.
Yeah.
Thank you very much for those comments, Professor Muthukumar. Yes, Professor Morota.
Okay. Yeah. Do you have a chance to work with orthopedic surgeon, or do you do everything by yourself?
The craniocervical work I do alone, but when it spans into the thoracic spine, then we use the orthopedic surgeons. Having said that, there's a growing interest in neurosurgeons doing spine fellowships to learn everything. And then the orthopedic surgeons, doing everything from the skull down. So we have to remember, as neurosurgeons, there's a lot more pediatric orthopedic spine surgeons than neurosurgeons, and they're out there, at least in our country, doing a lot of work, and many of them do a lot of very good work, and they're excellent surgeons. So that's my personal practice. I think in the future, people will be dual trained, or at least trained to be able to do everything from the top to the bottom. I think that's the ultimate goal.
Yeah.
Thank you very much. If I may ask Professor Brockmeyer one question, these children usually come to a specialist at a very later stage. I presume that is the experience you have got to, because they may be shopping around many places to show their children with deformity. What is the best age for intervention, or how early is the best time that would you recommend for intervention? I mean, instrumentation also in pediatric age group.
Yeah, so that's a good question. So I will start thinking about doing instrumentation at about 2.5 to 3 years of age, and it depends on the problem, right? And how large patients are. A normal 2 or 3 year old, typically with somebody who's really, really unstable, you can get instrumentation in. And then there's patients that are very small for their age. So you have to wait longer. Like I did a girl with spinal pivot dysplasia on Monday who was 5. I waited 5 years to do her case. So it's on a case-by-case basis. So like I said, as you do more and more, you get comfortable being able to predict what levels you're going to fuse, and then how early you can do that, and where you can get your instrumentation in. Okay, so there's no strict age. There's no hard cutoff for a number, but typically I'm starting to think about it about 3 years of age.
Thank you very much. Any questions from my co-host, Dr. Liu?
Yeah, thanks, Raja. Thanks, Prof, for a very nice presentation. I have 2 questions, Professor. One is regarding spinal cord edema, secondary to trauma. In which case the decompressive or laminectomy needed. Second question regarding instrumentation. Is ossification center is part of the consideration before a screw is placed? Thank you, Professor.
Yeah, good question. So again, yeah, early, if the patient has spinal cord injury and compression, early decompression is part of, there's a lot of literature in the adult spine world about ultra early decompression, early decompression. I think that the literature is within 8 to 12 hours is important to do the decompression. I think that's an important concept. And then as far as the growth plate goes, yeah, you do keep that into consideration. Typically, where we're placing the screws, there's not the synchondroses in the growth plates. Typically, those are more medially or located more in the midline, the C2 synchondroses. So in those, even if you place screws, it shouldn't disturb the growth plate. The growth plate should continue to function normally. And then you're just following that patient over time. So I don't worry too much about the growth plate because it isn't much of an issue, at least in my experience.
Thank you very much. I think we had a wonderful session, and I must thank Professor Brockmeyer and Professor Nobuhito Morita. We can take the final concluding remarks from Professor Morita before we move on to the second session.
Thank you very much, Doug, and yeah, that's it.
Well, thank you very much. So we'll move on to our second session, and I would like to invite Professor Basant Pant, who is here. Professor Pant, can you kindly switch on your mic? Yes. Thank you very much for joining, Professor Basant Pant. It's a great honor for us.
I'm sorry, I'm in the middle of my driving session back from a very difficult surgery today, but then, I'm very happy to be here again.
Thank you very much. Professor Horisawa, can you play it live from your end?
Okay, thank you for inviting me. I'm Shiro Horisawa from Tokyo Women's Medical University. So it's great to be here, and I'm very honored to talk my presentation in this conference. And first of all, I would like to introduce myself. I originally come from the Matsui city in the Shimane Prefecture, very countryside, western part of Japan. And a very beautiful locations and big castles beautiful castles are located in the center of the Matsue city, which is a national treasure castle. And you can see a very beautiful sunset at Lake Shinji. And you can enjoy huge, beautiful fireworks festival every summer. And there are so many hot springs in the Shimane prefecture. So the COVID-19 will settle down. Please come to Matsue City. And today I would like to talk about the surgical targets for surgical management for the hyperkinetic movement disorders. And there are so many surgical targets for the movement disorders, such as the motor thalamus, including a ventral olar or ventral intermediate nucleus, and the gross pallidus internus, GPI, and the subthalamic nucleus, and the pallidothalamic tract and the cerebrosalamic tract. So today I would like to mention mainly in the ventral olar and the ventral intermediate nucleus and the GPI and the pallidothalamic tract PTT. And it is necessary to know that there are two distinctive circuits associated with movement disorder pathophysiology and treatment. And one is a pallidal circuit, which is available for the treatment of dystonia or dyskinesia and rigidity, including the GPI or STN and the PTT and VO. And another circuit is a cerebral circuit, which is useful for tremor surgery. And currently, a surgical procedure for movement disorder is a mainstay surgical procedure is a deep brain stimulation. And another is ablative procedure, such as radiofrequency and gamma knife and focus ultrasound. And the deep brain stimulation is a gold standard surgery for majority of the movement disorders, Parkinson's disease and essential tremor and dystonia. And actually, the DBS is a very powerful and effective procedure for movement disorder surgery, but there are so many hardware-related complications, such as an infection or a lead fracture or battery malfunction. And even in Japan, the patients who live a remote area who cannot access to the DBS managing hospitals, so deep brain stimulation is not cannot be treated. Those patients cannot be treated by the deep brain stimulation. So in this presentation, I'd like to mention mainly about regioning surgery, such as the radiofrequency or focus ultrasound and the gamma knife. And the radiofrequency regioning is a basic procedure of the regioning procedure, which is performed under local anesthesia. And we perform it no hair shaving, and it can be finished by 50 to 30 minutes, and 4 to 5 the hospitalization days. And we use the 1x4 insulated electrode tip in the coagulation electrode, and we use a Lateral neurogenerator. And firstly, I'd like to introduce the ventral intermediate nucleus indication for hyperkinetic movement disorders, mainly a tremor surgery. This is a typical essential tremor. And she receives the right side VIM thalamotomy regioning. Only after the placement of the electrode, the tremor stopped, and then we performed the coagulation. So this patient had the bilateral hand tremor, and she received the left side VIM regioning. The tremor completely stopped, and this shaking hand on the right hand while writing also greatly improved after the left side VIM regioning. So the essential tremor is the best candidate of the regioning surgery. And this really is a dystonic tremor. Usually develops in the one side upper arm, and a very fast shaking hand compared to the essential tremor. But this condition is also well controlled by the VIM regioning. This is a postoperative condition, so the writing condition greatly improved. And this patient also have the right hand dystonic tremor. This is a preoperative condition. So that this is also a very good candidate of the VIM thermotomy. And this patient is a Parkinson's disease showing lasting tremor dominant Parkinson's disease. And this kinds of the tremor is also well controlled by the VIM surgery. Before making a permanent region, we stimulate the target using the electrical stimulation, and then we proceed permanent regioning. And the next target is a ventral olar of the thalamic nucleus, which consists of the pallidal circuit. This is available for the focal hand or foot dystonia, but this is not this is still unfamiliar for general neurosurgeons. And this procedure is originally from the Professor Siegfried in 1969 in Switzerland, and a highly effective treatment for writer's cramp. So the publication cure of tremorless writer's cramp by stereotactic thermotomy. So you can see this is a sagittal image of the thalamus, and this is the electrode, and the regioning here, this is the ventral olar nucleus. So writing condition became to be looks completely normal. And this is also available for many kinds of occupational task-specific focal hand dystonia, such as a musician's dystonia, which manifests the dystonic symptoms only while playing musical instruments, or hairdresser's dystonia, or other kinds of the task-specific focal dystonia. This is a typical writer's cramp. So you can see the hand stiffness of the right hand only while writing. This is a postoperative movie. The patient began to write very smoothly without stiffness. So the focal hand or dystonia, writer's cramp, is a very good candidate of a ventral olar nucleus regioning. This is the musician's dystonia, left hand affected professional drummer. This is a postoperative condition. This patient had a right wrist dystonia. So the focal hand dystonia in musicians is also a very good candidate. This is the hairdresser's relatively rare focal hand dystonia, and the left wrist involuntary flexion. And this is a postoperative movie 10 years ago. This is me, and the patient asked me to confirm the symptomatic improvement using cutting hair. And this is a very, very rare condition, watchmaker dystonia, very subtle dystonic movements in the right hand. The left hand movements were completely normal. But right hand, first and the second fingers involuntary flexion only while watchmaking. But other manual tasks were completely normal. So still, the patient had a dystonic symptoms of the right hand, and immediately after the regioning, the hand dystonic movements were improved significantly. And the effects are long-lasting, more than several years. This is a focal foot dystonia. This patient is a long distance runner with a left foot inversion dystonia. And the dystonic symptoms became so significant while stepping down. And this is 1 day after the surgery. So left foot inversion were completely improved. This is another patient, left foot. This patient also had a left foot inversion and relatively severe compared to the previous case. And this patient also had a right side ventricular regioning. This is a VO thalamotomy. So focal hand of the foot, distal limb dystonia is a very good candidate of the VO regioning. And the GPI is a very popular target for the deep brain stimulation for Parkinson's disease and dystonia. But this is also where this is a very useful for our regioning targets and the peridotomy. This patient is a cervical dystonia, neck rotation to the right, but left side peridotomy. This patient had a lateral chorus, and this lady also had a lateral chorus. This is after peridotomy. And the reference pattern or eyelid involuntary movements is also a very good candidate of the GPI surgery. And this is a mouse dystonia in musicians. So please look at the left mouse corner. You can hear the air leak sound from the left mouse corner. And he received the right side peridotomy. And the L-DOPA-induced dyskinesia in Parkinson's disease. This is also a very, very good candidate of a peridotomy. So the patient could not hold his body involuntary movements on peak L-DOPA conditions. But the serious complications associated with peridotomy is a delayed infarction on the posterior rim of the internal capsule. This is our cases suffered from a delayed cerebral infarction after peridotomy. And the left slide showing the coronal section of the T2 image, you can see this is a middle cerebral artery. The GPI region should be located around here, and always the stroke region located just above the GPI region, which is posterior rim of the internal capsule. So the patients always suffer from like hemiparesis or hemifacial palsy after this infarction, and at this moment, this is very difficult to predict. So this problem is very difficult to be solved in the peridotomy procedure. So we needed to search for another target. And that is a pyrothalamic tract. This is a white matter fiber bundles connecting with GPI and thalamic subnuclei. And this is the coronal as images. This is the GPI, and this is the thalamus. And the two fiber bundles originates from the GPI. One is a lenticular fasciculus, and another is under lenticularis. And the two fiber bundles merge at here, forward field H, and then sent to the thalamic subnuclei, such as the ventral anterior and the ventral lateral nucleus. And we place the lesion at here, which is folds field H1. The two fiber bundles merged here, and this is a paridoceramic tractotomy regioning. And the effects of the paridoceramic tractotomy, PTT, are completely similar to those of paridotomy. And this procedure was originally from the Spiegel and Weiss in 1950s. They called it a campotomy, campus folder aberration, for the treatment of a Parkinsonian tremor and rigidity. This is a corner section slice. The region FH is here. And but this procedure was abandoned with the unknown lesion. And Professor Daniel J. Monod in Switzerland revived this procedure and renamed it paridoceramic tractotomy for Parkinson's disease. And his lesion located just above the subthalamic nucleus and just below the thalamic's inferior border. And the number of patients, 41 patients received unilateral or bilateral paridoceramic tractotomy, and the UPDRS Part 3 score showed a 16% improvement. And the cardinal motor symptoms of the Parkinson's disease were improved after this procedure: tremor, kinesia, axial kinesia, and dyskinesia. So the effects were quite similar to those of a paridotomy in the treatment of a Parkinson's disease. And we followed him to confirm the effects of the paridoceramic tractotomy for Parkinson's disease. This is our first case. The region of the paridoceramic tractotomy is here, and the patients showed a 51.2% improvement of the UPDRS Part 3 score, and dyskinesia also greatly improved. This is a preoperative condition. In the off period, the patient's walking is like this. So, and on period, this is a pictal dyskinesia, very significant. And the patients also had a right foot painful dystonia. And we selected left side paridoceramic tractotomy. This is a one post-operative day. And without L-DOPA, the patients began to walk very smoothly. And even if the patient had the L-DOPA, you cannot see the dyskinetic movements of the trunk or neck. And the patient's right foot painful dystonia also completely improved after this procedure. So that's, and we proceeded to perform this paridoceramic tractotomy for dystonia. That is a relatively new indication. So this is our first case of the paridoceramic tractotomy for dystonia. And the effects were great. And the region was very small, but the effects the effects showed the BFMD RS dystonic rating scale showed a 74.3% improvement. This so very much improvement we confirmed in the treatment of dystonia. This is the major syndrome patients, cranial cervical involuntary movements. And the patients received the paridoceramic tractotomy. So the involuntary movements of the craniofacial region were greatly improved. And this patient had a myoclonic generalized dystonia with DYT28 genetic mutations. And this patient firstly received a paridotomy on the left side, but trunk bending was so severe condition. And this is a 2 postoperative day, 2 days after paridotomy, and the right side myoclonic movements were improved. However, trunk bending was still so significant. And 1 year after the first surgery, we selected the right side paridoceramic tractotomy. So this is a paridoceramic tractotomy region. This is a GPI, previous region. And the patient's trunk bending greatly improved after the second surgery. This is a typical cervical dystonia, neck rotation to the left. And he received a right side patelloceramic thoracotomy, only one side surgery. And this patient also had a lateral collis with the left hand dyskinetic movement. And the patient received the right side patelloceramic thoracotomy. And this is a tardive dystonia, drug-induced dystonia. So the patient could not stand or walk by herself due to the very severe trunk and bilateral legs involuntary movements. This is 1 week after the patelloceramic thoracotomy on the left side. And the patient began to walk and stand by herself without severe movement disorders. So PTT is a very good treatment target. And also it can be finished by 11 minutes. So very quick surgery. So patelloceramic thoracotomy should be evaluated in the treatment of movement disorders. And the hemorrhagic complication is one of the most serious problems associated with radiofrequency regioning. And from our recent analysis of the 721 cases, including a VO, VIM, GPI, and PTT, the 37 cases had an intracerebral hemorrhage. And among them, the 29 cases were asymptomatic hemorrhage, and the majority of the patients with the intracerebral hemorrhage were asymptomatic. And the final, at the last evaluation, only 2 patients had a prolonged neurological deficit. So just 0.3% of the patients suffered from a prolonged neurological deficit associated with intracerebral hemorrhage of the radiofrequency regioning. And the hypertension was the most significant risk factors of the hemorrhage. This is a representative images of the VO hemorrhage, VIM, and GPI, and the PTT. And the less invasive lesion surgery, such as the gamma knife and the focus ultrasound, are very important procedure for the movement disorder treatments. And the gamma knife is gamma knife regioning make intracranial radiation-induced necrosis on the target, which usually develops 3 to 6 months after the gamma knife thermotomy. So the delayed effects. This is a typical essential tremor cases after essential tremor case received on the left side VIM thermotomy, and 130 gray shots on the left VIM nucleus. This is the 1 year after the MRI. And the preoperative writing is this, and the writing condition was so nice 1 year after the treatment. So very difficult, complex Japanese character patient could write. And this is also available of the ventrolar regioning using a gamma knife for focal hand dystonia. And 130 gray shots on the left VO nucleus. And 1 month after the MRI, 1 month postoperative MRI, you cannot see any region. And at the 3 months post-treatment, you can see very small, tiny region on the ventrolar nucleus here. And the 6 months, the region began to be clearly visualized. And around 6 months, the patients began to notice the symptomatic improvement of the right hand. This is the preoperative condition. the first and the second fingers movements were dystonic, very slow compared to the left hand movements. Due to the advanced age, she received the gamma knife thermotomy. This is a 10 months post-treatment. I think this is a completely improved case after the gamma knife thermotomy. So, however, the very serious complications can happen after gamma knife thermotomy. This is a chronic encapsulated expanding hematoma case, which we report very recently. And this is the essential tremor patients received a 130 degree typical manner with a gamma knife thermotomy on the left side. And the 3 months and the 12 months and the 20 months, you can see T2 low intensity small region. And this is a posterior rim of the internal capsule highlighted. And the 26 months, the region became to be bigger, and 32 months, 38 months, and at 54 months post-treatment, the region was so big, just over the internal capsule. So the patients had a completely right side paralysis and sensory loss. So this is a very serious complication, and we cannot control it. So the gamma knife and the candidate with the gamma knife regioning should be very, very carefully selected. And we never do this procedure for younger patients. And the focus ultrasound is cutting edge lesioning technique for the treatment of movement disorders. And this is a thermal regioning using ultrasound focusing. So the patients received a focused ultrasound regioning in the MRI suites. And firstly, the patients received a low power sonication to confirm the symptomatic change. After the confirmation of the absence of the adverse events, the permanent region is made. So using MRI thermometry, the location of the lesion can be visualized while ultrasound treatment. This case is a focal hand dystonia. Had a left side ventral nucleus thermotomy using a focused ultrasound. This is a pianist, professional pianist, received a focused ultrasound ventral thermotomy. The preoperative condition, that you can see the light first and the fifth fingers involuntary flexion. So she could not play very easy tune. So this is a 1 week after FUS focused ultrasound treatment. The patients began to play very smoothly without stiffness or involuntary movements of the right hand. So she returned to the professional pianist. So lastly, I'd like to show the unusual cases of the movement disorders that can be treated by the lesioning surgery. The first case is a progressive supranuclear palsy, 71-year-old woman, and she had a gait disturbances and frequent falls, and the rigidity, a lacing tremor in the left hand, and also dystonic posture with the left foot, such as a dorsiflexion of the left foot. And she had a right side thermotomy. This is a preoperative condition. You can see the left hand shaking at the rest. And the right hand movement was normal, but left hand was very clumsy hand. And also she left foot posture was so dystonic. And the balance that the gait disorders, additionally the left foot dystonia, her gait conditions were very, very poor. And after the thermotomy, the clumsy hands improved and the dystonic posture also. So relatively better than before the surgery. And 1 year after this procedure, the resting tremor and dystonic symptoms were well controlled. However, the disease itself progressed with over time. So now she is a completely bedridden condition. And this is a juvenile Huntington disease, barely severe chorea in forelimbs and the body trunk. She received only left side pylorothalamic tractotomy. And she could not walk by herself before this procedure, and she began to walk by herself 6 months after the left side pylorothalamic tractotomy. So the chorea is a very good candidate of the lesioning procedure. This is a postoperative image of the pylorothalamic tractotomy, relatively big region. This is also this case the combined lesion on the VO and the PDT. So this is a moya disease. The patient had staged STA MCA biopsies, and she presented bilateral tremor. The resting tremor in the left foot and the left hand, but very mild. And you can see the left shaking foot. And now we're making a lesion. The tremor completely stopped. So the tremor associated with moya diseases can be controlled well by the lesioning via M thermotomy. So the surgical treatment for hyperkinetic movement disorders, the radiofrequency ablation is a safe and quick, effective procedure, and the experience and the knowledge of the radiofrequency lesioning is necessary for gamma knife and the focused ultrasound ablation and performed safely and effectively. And the gamma knife ablation is available for patients on the antiplatelet, on the anticoagulant therapy, which are not used for radiofrequency or focused ultrasound. So that gamma knife thermotomy is also still a very important procedure for specific populations. And the focused ultrasound ablation is less likely to happen intracerebral hemorrhage. As far as I know, there have been no case of intracerebral hemorrhage associated with focused ultrasound, and affects the same efficacy as the radiofrequency ablation. So the deep brain stimulation is not always necessary for the treatment of hyperkinetic movement disorders. Thank you for your attention.
Yeah, thank you very much, Professor Horisawa. It's a great honor to listen to your beautiful case presentations. And Horisawa is a wonderful friend of my country, and we have worked together in many occasions on movement disorders. And we share a common mentor, Professor Taira. And we firmly believe we are doing DBS listening. I had a presentation last time on listening, as Professor Horisawa just mentioned today. We are practicing both DBS and listening, but then we are very much confirmed that listening has got a big potential in many of the diseases and the problems that Professor Horisawa nicely represented today. And about there are a few comments that I want to make about the infarction that you see in the posterior capsule in GPI listening. We have also encountered a few cases, and we have written a paper about that. And we think that it is the thalamopreparatus that is coagulated during the radiofrequency ablation procedure. And so PTT, we are very interested to go into. We have just done 2 cases of PTT, and we are not yet able to say what exactly, how to evaluate PTT. But we are happy with GPI. We are happy with VO, BOP, BOA, BOP junctional, listening on focal dystonia, as you have very rightly mentioned, and VIM. And my question to Professor Horisawa is, you have reported, your center has reported about PTT also a target for epilepsy surgery, epileptic cases, intractable epilepsy cases. If you can, say something about that, because anterior thalamotomy or DBS on anterior thalamus is being proposed as a center for intractable epilepsy generally for generalized tonic-clonic seizure. So if you can, say something about that. And second is my question is, in many cases you have combined VIM and pallidothalamic tract combination, or can you do combination on both side PTT, bilateral? Because we last time I mentioned that we do bilateral GPI on a very severe dystonic patients. And in these cases, in dystonia, there's always lateralization. So we will make one side lesion big and the other side small. And we monitor the patient for speech and swallowing because we are doing it in awake surgery. So we monitor them intraoperatively. And then, if they don't have problem, we make few lesions on the opposite side also. If you can also comment on that procedure, please.
Okay, thank you. Very good question. And the pyrosamic tract for indication for epilepsy, you're asking?
Yeah.
Yeah, that is still a preliminary result that we had, but we have only 6 to 7 cases, and several patients. Just 2 patients completely free from the seizure, and we consider that the good indication of the pyrosamic tractotomy is focal bilateral to tonic clonic seizure, secondary generalization procedure from the focal epilepsy. That is already that was already reported by the Professor Jinnai, Dennosuke Jinnai, in 1960s to 70s in Japanese neurosurgeon. He originally invented this procedure. He called it the H-tomy for the epilepsy procedure, but we are not sure the other kinds of severe epilepsy, such as generalized conversion or juvenile myoclonic epilepsy or other kinds of epilepsy, which types of the epilepsy is the best candidate of this procedure. But at least I think the focal epilepsy comes from the frontal lobe or temporal lobe or parietal lobe. Maybe a very good maybe a very good candidate of the epilepsy procedure. So, and in the developing countries, this procedure may be a very good treatment option for epilepsy that cannot be, that is not available. Deep brain stimulation is not available for the health insurance.
Yeah.
And your second question is combined bilateral regioning.
Yeah.
For dystonia or movement disorder, you say.
Yeah. Like PTT or
yes. Okay.
Yeah.
And honestly, I have not experience of the bilateral pyrothermic tracheotomy because in my feelings, the patients after pyrothermic tracheotomy, some patients had a slightly dysphonic or reduced voice volume. And that the degree of the reduced voice volume only after unilateral pyrothermic tracheotomy, it seemed to be severe than GPI paridotomy. Okay. So the effects on the voice was so significant by PTT. So if the patient received the bilateral PTT, the very, very serious speech complications must happen. So we should avoid it. So in case of that, the patients need to the bilateral regioning. So we select the different targets, such as the GPI, in patients with a midline dystonia, a cervical or a generalized dystonia.
Central dystonia, yeah.
Yeah. So the one side PTT, contralateral side GPI, and that combined procedure are relatively safe. And from our experiences, I think that 50 to 60 cases from my experiences. But even if the staged different regioning combined surgery, the patients can have a very mild reduced voice volume, which does not interfere with the daily communications, but a relatively low, slight reduced voice volume and a mild dysarthria. But I think that is acceptable for the majority of the patients.
Thank you very much.
Yes.
Thank you very much, Professor Basant Pant and Professor Horisawa. I can only stand and applaud now with your wonderful results of beautiful procedures. Thank you very much. There is one question in the chat box asked by Dr. Murli Krishnan VP, and he says, nice to listen to you after a long time. Can I ask, do you focus PTT only for chorea, etc., or does GPI work for such hyperkinetic ones?
I'm sorry, I cannot hear you. Please say again.
You can see the question in the chat box. There is a Q&A.
Q&A, okay. Focus on PTT only for chorea. Yeah. Does it GPI for work? Okay. Yes, and originally in the history of the regioning surgery, the first indication of the paridotomy is a Hanchito's chorea. So the chorea is a very good indication of the GPI surgery. So the GPI must work for chorea or other hyperkinetic movement disorders.
Professor Horisawa, can I add?
Yeah.
I saw a few of the videos of Huntington's chorea in your video, and we have also a few cases, and the patient is very happy with the procedure. But when you look at the patient, somebody else look at the patient, they still have the choreatic movement, So when somebody else is observing, they are not happy. But the patient says, I'm much better. I'm more mobile and I can function better. So this is about 7 or 8 cases of Huntington's chorea that we have operated. And all of them are staged bilateral GPI in our center.
Mm-hmm.
And all of them say the same thing. They are not completely cured, but they are happy. Patients are happy, but the family member, they still see the choreatic movement,
Mm-hmm.
This is my experience.
Okay, so, and From my, actually, I only had only one cases, Huntington disease. So you have much more cases, but generally in Huntington disease patients, the GPI is very small or degenerated, so very difficult to target. So the correct targeting is slightly difficult. So in terms of the correct targeting, the paleothalamic tract is relatively easy to be located correctly because the PTT is just above the subthalamic nucleus and just lateral to the mammillothalamic tract. And the two targets, both targets are clearly visualized as a low intensity area in T2 MRI. So we can see indirectly a PTT with the nearly location of the STN and the mammillothalamic tract. So in Huntington disease, it's very difficult to target the GPI correctly.
So you mean when you target with MRI on the nucleus, not the coordinates?
Yes. Yes.
One more question I have for you is when I look at your MRI, post-op MRI on VIM lesioning or VOP lesioning on focal dystonia, your lesion seems to be quite big in comparison to what we are doing, you know. So what is the exposed tip and the size of the RF probe that you use?
Yes, that's a very important question. We use a 1x4 insulated tip. And in case of the VIM regioning, we usually make two trajectories on the VIM and 3 millimeter anterior trajectory. The two trajectories for regioning.
Okay.
Yeah. A total of two. And in VO regioning, several years ago, we made the 3 trajectories, 6 lesions, very big.
Yeah.
But we recently make the 2 trajectories, 4 regions, because the hotspot of the VO may be located in the posterior dorsal part of the VO nucleus. We are thinking that the anterior part of the VO is not necessary for the treatment of a focal hand dystonia. So posterior dorsal part of the VO is maybe a hotspot of the focal hand dystonia surgery. So that the size of the lesion became smaller and smaller recently.
Thank you very much.
Thank you very much. Any questions from my co-host, Dr. Libun Singh?
Yeah, thanks, Raja. Thanks, Professor, for a very nice presentation. I have 2 questions, Professor.
Yes.
In terms of the result of RF ablation, do you find the difference between the neurodegenerative cases compared to occupational induced? Does occupational induced have better result than neurodegenerative cases? My second question, Professor, you show the gamma knife induced recurrent bleeding. Do you think that is one of the cases that cavernoma formation due to the due to the gamma knife, Professor? Thank you.
So, the first question is about the results of the occupational dystonia.
Between occupational dystonia compared to the neurodegenerative cases.
Neurogenetics cases
compared to occupational induced. Does the result different?
At least as far as I know, the results are completely same. Not so different from the 2 disorders. And the second question is gamma knife
induced cavernoma.
Cavernoma.
Is it due to a cavernoma formation, the one recurrent bleeding?
Yeah, encapsulated bleeding, but we did not have the pathological findings, so we cannot diagnose this is a cavernoma or not. But maybe it seems to be a cavernoma, but very, very long-lasting chronic encapsulated hematoma, and we cannot, unfortunately, we cannot manage this region, and the region must region became very big on the posterior rim of the internal capsule, because the gamma knife shots on the VIM just medial to the posterior rim of the internal capsule. So I think that these complications cannot be managed by other articles. And usually these complications reported in case of the arterial venous malformation by the gamma knife thermotomy. And that can be removed safely. But this target on the VIM or stereotactic targets, deep-seated locations, so very difficult to approach. So this is a very serious and unsolved complications. So we should very, very carefully select the indications of the gamma knife. So at our hospital, at least more than 75 years or older patients have a gamma knife candidates.
Thank you, Professor.
Thank you very much. We have Professor Takashi Kon with us. Professor Takashi Kon, any questions from your side?
Yeah, thank you. I'm Dr. Kon from Tokyo Showa University. Thank you for a very detailed discussion. So I'm very informed. So I don't have the knowledge about functional neurosurgery, but I learned a lot. So I keep learning in the future. So thank you for the good information. Thank you.
Thank you, Professor Takashi Kon, for joining. With that, I can go back to our chair to hear his concluding remarks, Professor Basant Pant.
Yeah, thank you very much, Dr. Raza. It is a pleasure. In the parking lot, I'm listening to this after petroclival meningioma surgery. And I thank ACNS for a wonderful, Yoko Kato has been, wonderful and continuous education. So energetic, every week you are doing such a wonderful work. And I'm so happy to have to see Professor Morota, my good friend, today after a long time as a co-chairman on another session. And so functional neurosurgery, as I've said, it's going to come up like anything. And new residents should learn, and there should be more and more people who should get involved in functional neurosurgery. Functional neurosurgery is getting more and more less invasive, as the professor has just mentioned, like focal ultrasound listening. The limitation of focal ultrasound listening is that the temperature is not high enough. It should be 70 degrees, but with the focal ultrasound, the temperature is not high enough. So even if you get a cure, then there's a very, very high chance of recurrence. So if we can, correct that problem with technology, if the temperature can rise up to 70 or 75, then we can make permanent lesions, and DBS may go off, because DBS, deep brain stimulator, as I've said in my lecture, is a misnomer, because you are not stimulating anything in the brain. You are actually suppressing the brain by deep brain stimulation. And listening is also suppressing the brain. So it's one part of the brain which is hyperactive. We are trying to suppress that. So with that note, I thank you everybody for joining today's session, and I thank Dr. Raja and all of your team for a wonderful keep up the good work. Thank you very much.
Thank you very much for those kind words, Professor. I would like to close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to thank both speakers of today, Professor Douglas Brockmeyer and Professor Shiro Horisawa, and the chairs, Professor Nobuhito Morota and Professor Basant Pant, for their time and support for the educational activities of the ACNS. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And I also thank my co-host, Dr. Liu Bun Seng, for joining me today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much for joining.